Hey everyone, this is Mitch of All Trades and welcome back to my channel. If you're new here, welcome. My name is Michelle. I'm a registered nurse and a nurse practitioner student. If you're an oldie but a goodie, hey, what's up? Welcome back. It's good to have you back. Thank you for clicking on this video and choosing to watch this video and watch me once again. First of all, Happy New Year. Hope everyone's been well. In this video, I'm going to be talking about like a controversial issue in like the nursing community. Being that currently, for some of you guys that have been watching my journey, I worked as an ICU nurse for about 2 years and I recently switched and became an ER nurse. So this, for some of you guys are like, oh my gosh, like she went from one extreme to the other. A lot of you guys have your thoughts or whatever the case may be, and that's fine. I've explained in my previous video why I switched my specialty. So yeah, I already explained, how everything went down. So that's pretty much it. But I do know that working in the ICU and not working in the ER, a lot of you guys are probably wondering how my transition was. And it's funny because when I first started, or actually when I was in the process of getting hired to be an ER nurse, what I was being told consistently was a lot of ICU nurses can't handle working in the ER. A lot of ICU nurses can't do it. It's going to be a hard transition. You're going to have to try your best. Da, 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 da. Like I heard everything. And funny enough, like for me, it wasn't that bad of a transition. And I don't know if it's because like maybe the hospital that I was working in before was much more intense than the one I'm working in now, or maybe people just have different learning styles. But for me personally, I didn't really have that bad of an experience. I would say that yes, it is a different workflow. It's definitely a different zone, a different world over in the emergency department. But for me, I felt like I was just learning, almost like I was just learning a new work environment. Like for me, it wasn't really something so like overwhelming where I was like, you know what, I can't do it anymore. Granted that I do have a personality of an ICU nurse where I love organization. I don't like chaos like that. And if there's chaos, I like an organized chaos. However, I feel like I've still been able to adapt to the emergency room environment. So I hope that this video encourages somebody that's been thinking of switching or thinking of, trying out different things. And honestly, like, I would say do it. I'm always an advocate. Like if you ask me to do something, I'm never going to tell you not to do anything. I'm never going to discourage you to not do anything. I'm always tell you to do it unless like there's some like very like high danger reason or anything like that. I will always tell you to try new things or go out for what you think is best for you, because life is too short and there's no point of like struggling or suffering in a place that you don't really like, or like trying to just settle for one thing and just always wonder what life would be in another area. As much as my transition wasn't as bad, these are the things that I had to switch. For one, like I mentioned earlier, the workflow. In the ICU, I'm so used to like spending hours in the patient's room just doing a whole bunch of stuff. But in the ER, like I can't be in the patient's room no more than like 15 minutes. When they come in, you want to make sure you're able to get an IV in quick and hopefully at one shot, because the longer you stay there, the more work just piles up for you. You want to be able to go in, speak to them, and come out and get what you need to do. The workflow is definitely different, so I had to learn how to fasten my pace. Not really fasten my pace, but just fasten my interactions with patients, my patient care time, and just like my task. I had to quicken that up. Another thing that I had to learn was I had to learn protocols. ICU protocols are different from the ER protocols. And it is still under critical care, but I think I've been so trained to be so detailed in certain things that it can come to a fault when working in the ER, in the sense where I'm so focused on something which is valid but is not of the highest priority. There's different ways to skin a cat, and I think in the ER there's the different way that they do things that works for them, given that they have such a high patient volume, such a high turnover. I was also like trained to always wait for the doctors to give orders, but in the ER, I don't know if it's just because of the place that I'm working in right now, but we are allowed to put in standing orders. And for some of you guys that don't know, it's almost like an order set that's you can put in as a nurse for patients that come in for a specific complaint. So someone who comes in with chest pain has an order set of like specific labs and testings and all that stuff. Someone who comes in with abdominal pain has a specific order set with specific labs and testings and all that stuff. So you as a nurse have the ability to be proactive and put those orders in. So that was something new that I had to learn. Another major important thing, definitely, I forgot to even mention that, but this should be like the number one top of the list, is the patient ratio. Which is like a controversial issue because everyone feels like ICU nurses have only 2 patients and they don't do anything. And because I'm an ICU nurse, I have to defend my nurses and say that's not true. It's not 100% true, at least. I've definitely worked 12 hours nonstop with 2 patients who are very sick, and I haven't sat down or had a break, and that happens quite a lot. I think sometimes it all depends on the hospital you're working in and the kind of patient acuity that they receive. And being that my previous job was a level 1 trauma hospital, all my patients were very sick. So I don't know about y'all, but like for me, there were a lot of times where I was very occupied with 2 or 3 patients that were very sick. And granted, there's some days where it's not as busy, but I think that's for every unit and every hospital. But I'm not gonna act like I was just being lazy and stuff like that. No. Anyways, that's besides the point. So going from that kind of ratio to ER, where you can go to like have 7 patients or 6 patients, and it's almost like they're coming in and out at different times. It's not like you get them at the beginning of the shift and they're the same ones. You get them, they leave, someone else comes, they leave. So all of that is definitely, I think that's probably the part where a lot of people get so overwhelmed that they probably feel like they can't tolerate the emergency room department, which I understand, because that was definitely like a little shocking to me. Well, not really. Actually, it wasn't really that much of a shock, but it did get me a little bit overwhelmed. I think because I've had experience working as a med-surg nurse, where I've dealt with like high patient volumes, I was a little bit more accustomed to that kind of workflow. So it wasn't so far off of a learning gap for me because I already had that experience. So I kind of had an idea of how that works. However, that is something different that I had to adjust coming from the ICU to the ER. Oh, another thing I would say that I had to adjust is that in the ER, there's so many shifts. There's like the morning, the night, the mid shift. It's like a weird shift thing that they have going on down there, and then there are people that like come in at certain times of the day and come out. So every now and then you see more help come in or less help. Like it's like it's weird, and I think that it's just a method to their madness, and the more that you work there, the more you understand that language and get accustomed to it. From the outside looking in, it looks like chaos. Like you have someone come in at 7 a.m. Another nurse can come in at 11, another nurse can come in at 1, another nurse can come in at 3. Some of them, they're picking up additional shifts, which is appreciated, but it's like help is just coming from left and right. And I think and that can be seen as a good thing, because in a way we're all working together. So anyone comes in, they help out any way they can. I think in the ICU, we kind of like take territory over our patients, and I don't know why we get that way, but it can be almost like we're so possessive and territorial, where it's like, my patients, mine, don't touch, don't do anything. If the IV pump is beeping, tell me, don't touch it, like all that stuff. And I've had to learn, that's something I've had to learn, to be able to relinquish power over my patients and accept help from different people who are coming in at different times. And in that way, it helped bring like unity and I guess harmony and just teamwork working in the emergency room. So honestly, like, I've never been one to bash any specialty or think any specialty is better than the others, but I know a lot of people do that. That's not something I would ever do. I always appreciate every specialty, every nursing specialty, every nursing unit, because we all do the same thing in different ways and different capabilities. So with that being said, those are the couple of things that I've learned, couple of things that I've had to adjust transitioning from the ICU to the ER. If you have any questions, please let me know. Feel free to comment down below. Make sure you like this video, subscribe, and share it to a friend. Thank you so much for watching. I'll see you in my next clip. Bye.